when patient will come back to you, then you will do the transvaginal ultrasonography when there is no contraindication. Okay, so that is important, that how we gonna get the full bladder. So this is a very important and for transvaginal. How we're going to prepare the bladder is very simple. You will instruct the patient, you will ask first, how is the bladder? Is it full? Oh no, I just empty your bladder. Okay, fantastic. So then patient will go on the bed and you're going to do the ultrasonography. But if patient says, no, I believe I'm full or partially full, so most of the time they will do the ultrasonography with the full bladder, partial full bladder, then they will ask for empty or complete as much as possible and come back. A little urine in the bladder acts as a landmark, so it is good, not a problem. So then they will do the transvaginal ultrasonography with empty bladder. Translabial. Translabial means also known as transperineal. So they use the transducer. Which transducer? It could be curvilinear transducer, it could be linear transducer, or even it could be transvaginal high frequency transducer. Why? Because the translabial approach is not good to see the pathology in the fundus of the uterus. It's not good when the uterus is gravid, means pregnant, and a big uterus. No. It's not good to see the ovaries, fallopian tube, adnexa. No, no, no. It is used to see the lower segment of the uterus. That includes the vagina, cervix, and up to the isthmus. Okay? And you can clearly measure the length of the cervix. You can clearly see, is there any pathology in the cervical canal? And also this approach is used for the pregnancy in the second and third trimester who is having symptom of placenta previa. So they like to see the margin of the placenta. Is it covering the internal os or no? And it is also used to see the blockage of the vagina, gynaectasia, imperforated hymen, and also the incontinence of the urine. Okay? So it can help to see the urethra, bladder neck, and the closing and opening of the sphincters. So in that way we can use it for that incontinence check up to. Okay, so the purpose is different, and you can use the linear transducer or curvilinear transducer. Also you can use the transvaginal transducer. We're going to put the transducer on the labia or in between the labia, anterior to the vaginal canal, that you can see your desired organs. You can also put the transducer over the perineum, and you know what is the perineum. It is the space between the posterior wall of the vagina and the anterior wall of the anus. That area is known as perineum. You can scan the lower uterine segment through the perineum. Fantastic. You can get it. Okay? So, preparation depends on the ways or the types of ultrasonography you are going to see. What are the indications? What is your focus? What you are going to see? Okay, based on that, patient's preparation. And bladder fullness, and patient will be asked, have a shower, cleanness, and no underwear, and patient will be given a gown or disposable gown, and patient will come to you. Okay, and patient will be ready. Then we will discuss everything in the total technique about the position. Then transducer selection. For the transabdominal, usually 3.5 is for the average body habitus people. But if the patient is obese, then we use low frequency, like a 2.5. If the patient is skinny, young and skinny, we use higher frequency, like a 5 megahertz. That's good enough. For transvaginal, it is actually the curvilinear, curved head transducer, and is a stick. It goes inside the vagina up to the vaginal fornix or up to the cervix external os, and its frequency is 7.5 megahertz. Usually it is 6 to 8 megahertz, so 7.5 is fantastic. Higher frequency. Why higher frequency? Because the transducer head is going close to the external os, close to the cervix, close to the ovaries, close to the uterus. So all those reproductive organs are considered as now superficial organ. So superficial organs are scanned by the higher frequency transducer. Okay, it is very important. And the beam of from the transvaginal transducer is very widely diverged. Okay, and its resolution is fantastic. Okay, and you can hold lot of space, lot of organs, and we're going to learn about their orientation too. And for the transperineal that I mentioned to you, you can use anyone. But if you want to see some more superficial, so then I will ask you use the high frequency linear sequential transducer. Okay, linear sequential transducer, that is used for the thyroid gland, for the breast, for the scrotum. Okay, use those one. You can see better bladder neck and the urethra to rule out so urinary incontinence present or not. Okay, I believe you are understanding that not any transducer can be used for all purposes. No. Because their indications are different. Their choices are different too. And patient will be informed and explained, okay, about the mechanism, how we are going to do that. Okay, so now I will come to the total technique. But for the total technique, I just need to cover this part before the total technique. Indication for transabdominal ultrasonography. What are the indications? So normally, if patient is young and having irregular period, heavy bleeding, pain, and feeling a mess, so they will order, okay, go for GYN protocol. Simply transabdominal ultrasonography and transvaginal ultrasonography. Now question, if the girl is very young and never had any biological activities, if religiously prohibited, and if patient says, no, I don't want that, I'm still virgin, you cannot do transvaginal examination. You can. So then you have to do the transabdomen with the full bladder. Can I get all those images, required images? Yes, most of the time you will get it. Sometimes you may not get it if the bowel movement is too much and there is dirty shadows are there. But if the bladder is full enough, then I can tell you there is a lot of chance you can complete the whole GYN protocol. You can. And for the GYN specifically, they need a transvaginal approach. They need a specifically, because they want to see the ovaries. They want to see the follicles. They want to see the uterine endometrium clearly. It is thickened, so it could be a polyp too. In the cervical canal, there might be a polyp. A lot of images in transvesical, transabdominal are not very good enough resolution and inadequate. But in transvaginal, you can see it clearly. That's why they do both transvesical and transvaginal. You can see better adnexal area in transvaginal approach. You can see better cervical canal, uterine canal, and you can also see the fallopian tube if it is dilated. You might see some PID, endometriosis, yes. Okay, so these are the indication, and translabial I mentioned to you. So gynaectasia, imperforated hymen. In gynaectasia, imperforated hymen, that may cause the hematocolpos, hematometros, or hematometrocolpos. And they might see the vagina partially formed, partially did not. Okay, and they might see some very superficial pathology in the birth canal. Okay, and they can also see any herniation, femoral hernia. Yes, there might be femoral hernia. And there might be some lymph node enlargement. So they will go by the translabial approach. and urinary incontinence. Urinary incontinence to rule out. Okay, so patient may have urinary incontinence. A little stress, little coughing, straining, the urine comes out. Okay, so now let's go with the total technique for the GYN protocol and also the scanning method. Okay, the idea, goal and objectives of the study of total technique and the scanning method. What are the goal and objectives? What is our expectation? What is our expectation? Our expectation is to get something that correlates with the patient sign symptoms. So objective and expectation to get something that correlates with the patient's signs and symptoms. That is our focus. So then you need to understand that in GYN, female reproductive organ, what are the area where I can see the pathology? What are those areas that we need to understand, that areas of interest? We need to understand that I need to look for the area of interest. What are those? Uterus and endometrium. Fallopian tubes. Ovaries. And when you see the uterus, you have to look for the fundus, body, and the cervix. And number 5, vagina. And number 6, adnexa. Okay, so these are my points of interest, areas of interest that I have to look for this. When patient has pain, simply patient came with the lower abdominal pain, we're going to take the LMP history. We're going to write down the LMP date on the screen. It's recorded, documented. Then in your mind you have to think, okay, I need to see all these parts. But is it possible if I take a very nice history from the patient? Is it possible to rule out the pathology is in the ovary or in the uterus or in the vagina or in the fallopian tube? If pathology is in the uterus, so is it in the muscle of the uterus or in the endometrium? Use your intellectuality. There are some diseases specifically with the history, signs, symptoms, physical examination and the blood test, you can rule out that no, this disease is from uterus, this disease is from ovary, this disease is from vagina or fallopian tube, or simply from the bladder because the pain is in the lower pelvis. Okay, start using your intellectuality. That's the way you will understand and you will be able to focus. Focus your intention that what you are looking for. What is my expectation? I want to get something that correlate with the patient's complaint. And if I don't get anything, then I will say it could be a false pain or my examination is an error. Very important. Sonographers in this country, you are authorized to scan, to palpate, to do the physical examination too. But in this country, you are not authorized to write a report. But you can give the preliminary report to the radiologist. You will be working under radiologist guidance. Okay? So, uterus, endometrium, fallopian tube, ovaries, vagina, adnexa, those can be evaluated. That is the goal and objectives. Okay? Okay? The total technique comes from, you will get a requisition. A requisition means a paper where it is written what type of examination they needed. That is written over there. And what was the patient's chief complaint? It is written. Okay? Requisition or referral. Okay, and there will be patient's last name, first name, date of birth, medical MR number if it is there. You have to match with that to get the correct patient. So, patient will have an appointment and the patient will come to the clinic. Patient is in the waiting room and you ask the patient by name. Then if patient is capable of following you, patient will walk and come to you. Sometimes you will see the patient is in the wheelchair if the patient comes from the ER or patient is on the stretcher. Okay? Then you're going to take the patient in your room. Identify the patient. Okay? You're going to look for the last name, first name, date of birth, MR number, medical record number, and ask patient, do you know why you are here for today? And who is your referral doctor? If it matches, then you got the correct patient. You got the correct patient. Okay, so now start taking the history. Start taking the history. Just ask why you are here for today. Even though you can do it before changing the dress, because there sometimes you will see that changing room is attached with your exam room, or if not, so then let the patient do the dress change first. Okay, start taking the history or dress change. Make sure this dress change does not interfere or disrupt the privacy. You have to maintain the privacy, or called modesty. Okay? So when patient will come to your room, then you're going to start taking the history. Okay? So you can do like this, changing the number. Okay? So then patient is asked for on the bed. Then ask patient, I see you came. Okay, can you confirm me why you are here for today? Patient is giving the history. Patient is giving the history, and take a detailed elaboration to understand. You have asked a question. This is the first time you are taking this ultrasound, you are having this ultrasound. If it is no, you did it before, so what was the reason? Do you know what was the diagnosis they made? Then you have to take the history, this pain, then characterize the pain, how long the pain is, what is the nature of the pain is, how frequent. Why you are asking all those questions? Because I am figuring out that where is the pathology. Where is the pathology could be, if there is any. Then take the family history, take the medicine history, personal life history, marital history, obstetrical history, and first day of last period,